Good morning. This talk is about making the best of a bad situation. And it's true, while your program says disaster ethics, in fact, we're going to focus more on disaster triage. Specifically, when you start to run out of precious resources, how do you decide who gets what? So let me set the scenario for you. You're working in your hospital on a Saturday evening. It's a little bit quiet, the administrators have gone home, just the weekend people are there, and out in your city, there is a rock concert going on. Thousands of people are there. You're expecting that later, in fact, your hospital's going to see a number of intoxicated patients coming through. And then your phone starts going crazy, and it's your Twitter feed. And when you look at it, you see, in fact, that 2 bombs have been detonated at the concert. There are thousands of people there. Every ambulance in town is now headed your way. We all operate under a scenario, I think, most days where we don't have enough beds, right? Who is short of an ICU bed on a regular basis? Probably all of us. But what I want to talk about here is what you do when that scarcity is amplified by an order of magnitude. So you're there, you're working away. Patients are pouring in. Your team is all hands on deck. You're managing. Everybody is well trained. Until you turn to somebody and you say, I've just intubated this patient. Please get me a ventilator. And they say, there are no more ventilators. What you do then is quite pivotal. The actions and decisions you're going to make in the next few hours will have an enormous impact. So how do you decide who gets what? And so at my place, I'm the medical director for emergency preparedness. So part of my job is to dream up disasters and then figure out a plan for managing them. Most of the time, I find this pretty fun. This one I find hard. I'm going to show you my draft plan for this. I think this is a controversial issue, and I think it needs input and feedback. So I bring it to you here at SMACC, because if there was ever a place to get feedback, it's here. But I also think we need to get this discussion out in the open. This is something that doesn't get a lot of talk, and it probably deserves to see more daylight. To be clear, I am not talking about start triage tags or their equivalents. These are great. This is pretty well sorted out. We use these in disaster situations to decide who to see first. In general, you're seeing the reds. These are the unstable patients or your immediate priority. This works marvelously when you have 1 red patient and at least 1 bed. But what do you do if you only have 1 bed and you have 3 reds, or you have 5, or you have 20? How do you make those decisions? Who has a plan for this at their place? Do you know if your place has a plan? I will tell you that very few places have a written plan for this. There is no plan, which means the people there at the time are just making the call. And I think we could probably all agree that this is not the time when you want to wing it. It would be really nice to have some criteria or some guidance to fall back on, something that your chiefs have signed off on, something that your hospital has signed off on. So when we look to the established literature, we can get a bit of a background for what is out there. And in fact, most of the papers conclude with the idea that we really need to have a plan like this. But then there is no plan in the paper. They imply that somebody else should write this plan. Why is that, right? Doesn't seem that hard. But people don't like to talk about this issue. Nobody even wants to raise the concept that we might palliate somebody rather than offer them an ICU bed. People are afraid of the legal issues. They're afraid of backlash from patients. They're afraid of guilt they may feel by not being able to offer patients everything, or not be able to offer patients what we would offer them under normal circumstances. So people don't talk about this issue. Instead, they duck. They hope it doesn't happen. Chances are it won't happen, right? It won't happen to you. Or hopefully some other person will be on shift that night, right? And so we don't write the plan, and the healthcare workers who happen to be there that night are on their own. But imagine a world where you have a plan with clear criteria, signed off by your hospital, signed off by your health regions, maybe even signed off by your government, because the issue of legal protection for healthcare workers under these circumstances is important. If you have this type of plan, not only does it keep us safer as a community of healthcare workers, but more importantly, this is there to help us optimize outcomes for those patients. If we're going to achieve the best possible outcomes, probably would help us to have a plan. So you're there in your unit, it's not going well. Things are descending into chaos, you've got 1 million red patients, and for the sake of argument, we're going to argue that our scarce resource is an ICU bed. But this concept is scalable, right? Any scarce resource could be applicable here, whether it's an operating room, a transfusion, a ventilator. But for the sake of argument for today, let's take it as an ICU bed is what you're short of. Now you need your plan. When we look to the literature, there are a number of components that should go into this type of plan. You need some overarching principles for how you make these decisions. There have to be clear inclusion and exclusion criteria, and then a defined process for how this will be operationalized. You can't just pass somebody a piece of paper and expect them to do this cold. So let's talk through these 3 things. The first step here, the first guiding principle, is that you want to have this plan, and then you never want to use it. So step 1 is mitigation, and mitigation is probably steps 2, 3, 4, and 5. You want to do everything possible to avoid ever having to triage or ration your scarce resources. This means you're going to share with your partner hospitals. You're going to urgently order in supplies. You're going to repurpose what you have. You are going to MacGyver something. You are going to work it out so that you make enough to go around. You can't use this plan without exhausting all of your mitigation opportunities. The next guiding principle relates to the ethics. In our normal circumstance, we are trained to offer our best for every single patient. Operating in a disaster requires a shift to the utilitarian philosophy, which expresses that we should be trying to achieve the greatest good for the greatest number. This sounds pretty good on the surface, right? The greatest good for the greatest number, it sounds very positive. But in fact, what that still means is not everybody is going to get what they need. And knowing that, we are still trying to optimize the outcomes. This is a difficult concept for people. It is tough psychologically to make that shift to scarcity, and this is part of why people don't talk about this issue. The third guiding principle, I believe, is this, and I mentioned it a little bit earlier. I think developing these plans needs to be a public process. You cannot do this in a covert manner. You can't spring this plan on your patients or your community in the heat of the moment. We need to have this discussion out loud and, in fact, engage our community stakeholders so that everybody knows what the plan is. Inclusion and exclusion criteria are where it starts to get serious. Most of these, when you look at the literature, there are very few papers out there that describe clear inclusions and exclusions. I can find about 8. If you have one, send it to me. But when we look at them, you can collate them, they all have similar themes. And most of these came out of the work that was done after SARS, or in relation to the various influenza outbreaks that we've had. So you have all these people, they all want a bed, and the way this works is that they have to have an inclusion criteria, and they have to have none of the exclusions. The inclusions are pretty straightforward, and everybody seems to agree on these. That to qualify for an ICU bed, you either need a mechanical ventilator, you need to require one, or you need to have fluid refractory shock requiring vasopressors. These are pretty standard in the literature, and I actually think in a real disaster, I would probably just run my vasopressors on the floor and save my ICU bed for the mechanical ventilators. But these are the proposed inclusions. They're fairly straightforward. The exclusions are where it gets tougher. These are the standard exclusions available in the literature. If you have one of these, you would not be a candidate for the ICU bed. So cardiac arrest specifically means unwitnessed, recurrent, or refractory to standard therapy cardiac arrest. Severe trauma with a revised trauma score less than 2. Severe burns, which would be defined as inhalational injury or a significant body surface area. Metastatic malignancy with poor prognosis. Do not resuscitate status, which I think is self-explanatory. Or severe end organ failure at baseline. This one sounds quite benign, but it's probably one of the most controversial, because this is what that looks like. If you have any of these, you would not be a candidate for an ICU bed. New York Heart Association class 3 or 4 congestive heart failure, chronic lung disease with a low FEV1, liver disease with a high MELD score, severe baseline dementia, severe irreversible neurologic or neuromuscular condition, and immunocompromise. This is where it gets really hard, because when I look at my ICU today, all of my patients in there have this, right? It must be the same at your place. So what do we do with these criteria when we're going to deny incoming patients ICU on the basis of them? But we already have a unit full of these patients there. And this is the piece of this that has never been well worked out. This is the piece of this that is still debated and controversial, and part of why nobody writes down their plan. Let's look at the process. The first step is you need to have a clear set of criteria for when you're actually going to declare a crisis situation and when you're going to activate your plan. This ideally is not coming from individual healthcare workers. It should come at least from the hospital level, if not from your health region or your government. That also allows your government to have the opportunity to give legal protection for the healthcare workers. You need a team to do this. You can't ask one individual on their own to make these decisions, so the common way to operationalize this is to have a team that's multidisciplinary, including probably a consultant intensivist, a nurse or a respiratory therapist. I think having an ethicist or a social worker would be a great idea. They assess the patients using anonymized patient data to decide who qualifies for a bed. I think that team would need to have dedicated psychological support to help them, because that's probably the toughest job to live with. The literature recommends that we have a review board overseeing this process to make sure it's applied in a fair and ethical manner. The concept of having a live appeals board is also out there. Most places don't recommend this because having a live appeals process would be thought to be too slow. I think almost everybody would appeal, and you might not be able to make decisions in the timely fashion that you needed. There obviously needs to be excellent alternatives for patients who are denied ICU care. They either need excellent general medical care or palliative care, but they still need to be offered the best care available under those circumstances. And then we come back to this issue of reassessing patients. So if you initially become an ICU candidate, in general, probably everybody should be reassessed at the 48 to 72-hour mark to see if they still meet criteria. If they do, they would remain in the ICU. If they did not, they would be discharged. But the sticky part here is, do you just apply this to the new patients coming in, or do you use that same process for your patients currently in the ICU? Do you discharge somebody currently in your ICU to make room for somebody who may be a better candidate? And that varies depending on where you work. In some places, I don't even know the legality of whether people would be willing to try that. But those are the questions that we face. How are you doing? Usually when I talk about this, by this stage, people are pretty overwhelmed. This is okay, this is normal. This is why nobody talks about this, why nobody publishes papers on this. But I still think having the discussion is valuable, and it's much easier to have it now, in the broad light of day, when there is no crisis. Certainly, if we're ever going to have it, it needs to be now rather than in the heat of the moment. So I'm interested in your feedback. You can tweet me your thoughts. If you need more than 140 characters, you can go to my website and leave a comment there. I have no financial stake in this. There's no money to be made in disaster planning like this. But I have, there's no money. But I have it, in fact, they would probably pay me not to do it. But I do have a significant academic interest in making this as excellent as possible. Because sometimes in life, you hit that point where you don't want to be. I want to have this plan and never use it. I want it to sit in the corner and get dusty. But I want to know that it's there for in case we get to that unthinkable moment, that we have that. So here's my summary. Before you're ever considering triaging your scarce resources, you must mitigate. And in the best case scenario, mitigation works and you never use your triage plan. If mitigation fails, you're moving to the utilitarian philosophy of ethics. You need clear activation triggers from all of your stakeholders in your community. You need a dedicated team to roll this out. You need to make sure you have a monitored ethical process. And I believe this discussion, while difficult, is worth it if it helps us save more lives. So I prefer to be prepared. I prefer to develop skills and tools that I hope I will never use, both for the safety of all of us and for the best possible outcomes for our patients. Thank you very much for your attention.
Fantastic, fantastic.
Thank you.
So I'm proud to introduce our Twitter moderator for today, Mariki, or MJ Slabbert. People may know her as Gas and Air Critical Care Doc. She's been hopefully getting some tweets coming through with some questions from the audience. Continue tweeting to @MJ Slabbert for the remainder of the session. Have you got anything
it's
interesting?
been fantastic. I think I might stay on the stage for the rest of the day because the signal's definitely better up here, guys. So thank you for everybody's comments. There's been quite a few comments. I think the UK Twitterati feels that your exclusion criteria during a crisis is sort of almost their normal exclusion criteria. And having worked in Canada, I can tell you it's much different population that gets admitted to Canadian ICUs. There were some interesting comments from Dr. Mick Malloy, essentially about pubs and throwing people out of the boat. But an interesting question from him was, does your discharge criteria change during a pandemic? People you might have kept in the ICU a little bit longer when there is, do you throw people out of the boat to create space for more reds?
Do we currently throw them out of the boat? No. And that's the question. This is a very country-specific phenomena, right? Different jurisdictions already have different admission and discharge policies. But certainly lots of people with multi-organ disease at baseline get into the ICUs in Canada, and discharging them is a problem, which is why criteria like this would help us.
Sure. And do you think predicted prognosis and ability to contribute to life in an economic way, again, should play a role if you're faced with one ICU bed and maybe a 20-year-old trauma patient with a predicted good outcome who would go back to work, get a salary, or then, maybe another patient that might not have the ability to contribute to society again. Should that play a role in your inclusion criteria?
Absolutely right. So age is an interesting factor that gets debated in many of these, much of this literature. It depends how you define the greatest good for the greatest number. So if you define greatest good as years of life or life potential expected, then triaging younger people ahead of older people is probably the way to go. My particular institution has strong antibodies to that phenomena, and we're still working through that issue. Age is not currently allowed to be on my list.
That's right, yeah. Working in the same city as you, I can confirm that is true. I think Ming hasn't been mentioned enough in this conference, so heads up to Ming. Hey, Ming. He's been tweeting. He says, in the next flu pandemic, how would you allocate ECMO resources nationally? And do you think it's a good role to maybe pre-position ventilators everywhere in small clinics and hospitals? And in your opinion, what do you think might be the next big pandemic?
Okay, Min, that was 3 questions in one. Do I think we should put ventilators everywhere in small clinics and hospitals? Only if people know how to turn it on and set the buttons. So yes, if there's training and no otherwise. What do I think the next big pandemic will be? I think we're overdue, really, for another viral flu. So I look forward to the next one of those. No, that was facetious. And what was his third part?
And the ECMO setup, how would you...
Oh, ECMO. Right, ECMO is another great area where you probably have to make decisions because, at least for us in Canada, this is still a scarce resource. I don't have ECMO for everybody. You need to decide who is your most appropriate candidate, so it's very translatable to this work.
Awesome. Thanks, that's about it from the Twitterati.
Well, wonderful. Thank you very much. Let's have another round of applause, Sara
Thank you.
Gray.